Hi guys, my name is Nurjana binti Abdul Aziz and this is my video presentation for subject MRD444 Radiographic Image Evaluation. Okay, let's go guys. Let's start the journey. In this video, we will go through the radiographic anatomy, criteria of positioning, criteria of exposure factor, and lastly, assessment method. Before we go deeper, we will learn about radiographic anatomy of lateral elbow. This is overview radiographic anatomy of lateral elbow. Lateral elbow must include distal humerus, medial supracondyle ridge, capitulum, medial epicondyle, olecranon, trochlea, coronal process, head of radius, radial tuberosity, proximal radius, and proximal ulna. Next, we are going to discuss about criteria of positioning for lateral elbow. The first criteria that indicates elbow is in true lateral position is the elbow joint visualized flat 90 degrees on the radiograph. Secondly, the elbow joint space is open, radial head and coronal process are superimposed. Thirdly, radial tuberosity is seen not in profile and superimposed with the radius. Next, the elbow joint is at the center of collimated field and include 1/3 proximal radius ulna, distal humerus and surrounding soft tissue. Lastly, as the elbow is flexed 90 degrees, the distal humerus must show 3 concentric arcs. 3 concentric arcs are made up of 3 anatomy. The yellow line shows trochlea sulcus. The green color shows outer ridge of capitulum and trochlea, while the pink line indicates trochlea notch of ulna. In this section, I will explain the factors affecting true lateral elbow image. Why the accurate positioning is very important. The distal humerus, radial head, and coronal process are misaligned when the proximal humerus and distal forearm are inaccurately positioned. Proximal humerus positioning determines the alignment of the distal surfaces of the capitulum and medial trochlea, whereas distal forearm positioning determines the epi-alignment of the capitulum and medial trochlea. The first factor affecting true lateral of elbow is mispositioning of distal forearm. As we can see, this is what will happen when we position patient's distal forearm too low. The radial head is distal to the coronal process and the capitulum will appear too far anterior to the medial trochlea. Next, the image shows that the distal forearm is elevated too high from the elbow. As a result, the radial head will be proximal to the coronal process and the capitulum will show too far posterior to the medial trochlea. In addition, the mispositioning of proximal humerus also will affecting the true lateral image of elbow. As we can see from the image, the radial head is positioned too far posteriorly on the coronal process, and the distal surface of the capitulum is demonstrated too far distal to the distal surface of medial trochlea, which indicates that the patient was positioned with the proximal humerus elevated. How to correct this? We have to lower the proximal humerus until the humeral epicondyle are superimposed and the humerus is positioned parallel with the IR. Okay, let's see what will happen when the proximal humerus is positioned too low from the elbow. The image shows the radial head is positioned anterior on the coronoid process, and the distal surface of the capitulum is too far proximal to the distal surface of the medial trochlea, which indicates that the patient was positioned with the proximal humerus depressed. To improve this, we have to elevate the proximal humerus until the humeral epicondyles are superimposed and the humerus is positioned parallel with the IR. Okay guys, we take a look at this example of incorrect positioning of lateral elbow. The first image shows that the elbow joint space is open and the distal humerus demonstrates accurate alignment. However, the radial tuberosity is demonstrated in profile anteriorly, which indicates that the wrist and hand were supinated. To improve this, we have to rotate the patient's hand into lateral position. The next image shows that the olecranon position within the olecranon fossa and radial tuberosity demonstrated in profile posteriorly. This indicate that the elbow is extended. To improve this, we can flex the elbow into 90 degrees if possible. Next, we will discuss about criteria of exposure factor. Okay, let's take a look. This is a guideline to evaluate whether the exposure factor applied is adequate or not. The KVP is used to contribute the radiographic contrast. For thick structure, we will evaluate the bony cortical outline of coronoid process or humeral condyle, while for thin structure, we will evaluate the bony cortical outline of olecranon process or anterior and supinator fat pads outline. On the other hand, the MAS is used to contribute in image density and details. For thick structure, it is important to visualize the bony trabecular pattern of coronoid or humeral condyle, while for thin structure, we will evaluate the bony trabecular pattern of olecranon process. Let's move on to see some examples of images with incorrect exposure factor. This image shows a lateral elbow. For thick structure, the bony cortical outline of coronoid or humeral condyle and bony trabecular pattern of coronoid or humeral condyle can be seen. However, the exposure factor used is inadequate to visualize both bony cortical outline of olecranon process and bony trabecular pattern of olecranon process. Also, the anterior and supinator fat pads outline cannot be seen, hence indicate that the image is over-penetrate. Next, the image shows the lateral elbow. The KVP used is inadequate for penetration and radiographic contrast. This is because the bony cortical outline of the thick structure, which is coronoid or humeral condyle, cannot be seen on the radiograph, while the bony cortical outline for thin structure, such as olecranon process or anterior and supinator fat pads outline, can be seen on the radiograph. For MAS aspect, it is also insufficient to visualize the density and details of structure. This is because the bony trabecular patterns of thick structure such as coronoid and humeral condyle cannot be seen. Meanwhile, for thin structure, the bony trabecular pattern is well visualized and can be seen on the radiograph. As a conclusion, this image is in under penetration. In this session, we will go through on how to critique a lateral elbow X-ray using Passman image evaluation technique, which stands for projection and positioning, alignment, collimation, exposure factor, marker, aesthetic value, and name. P. Positioning and projection really refers to whether the patient is in the correct position or not. Are they rotated? Is joint spaces is open? Are they in a correct projection? A. Referring to alignment. Is the patient correctly positioned at the center of IR? There are three factors that used to evaluate the alignment. First, the alignment between X-ray tube to patient. Secondly, the alignment between X-ray tube to the IR. And last one, the alignment between patient to IR. C for collimation. Collimation is similar to area but is mainly referring to how well the beam has been collimated, side to side and top to the bottom. It is indicate what anatomy should included in the collimated field. E is referring to the exposure factor, which is KVP and MAS. Was it appropriate for that structure size and density? Was the image has the enough contrast? And for marker, are there any evidence of right or left marker visualized on the radiograph? Was it in the correct site? Was it doesn't superimpose with any region of interest? A for aesthetic. It is evaluated with the size of film. Is the size of film used is correct? Does it enough big to visualize all the region of interest? Are there any evidence of artifact demonstrated on the radiograph? And the last one is N. N is stand for name. Is the ID is correct? Is the image correctly identified the correct patient? Also, name is mandatory for every radiograph. The last part of this journey is we will going to critique the radiograph of lateral elbow. This is the radiograph that we will critique with the Passman method. Firstly, we will going to projection and positioning. This is a radiograph of an elbow with a projection of lateral view. I say so because there is three concentric arcs are visualized on the radiograph. 1/3 of humerus and 1/3 of radius ulna are included on the radiograph. The first point of positioning is the elbow is flexed 90 degrees. Hence, there is no improvement needed. Secondly, the elbow joint is open, radial head and coronal process are superimposed to each other. Thirdly, at the distal humerus, there is three concentric arcs are visualized. Hence, there is no improvement needed for this positioning. However, the radial tuberosity is demonstrated in profile posteriorly, which indicates that the distal radius ulna might be in prone position. To improve this, rotate the wrist until it placed in lateral position. Next, we will discuss about the alignment. The alignment between X-ray tube and the IR is evaluated by comparing the distance between the edge of collimation to the edge of the film. In this radiograph, the alignment between X-ray tube and the IR is incorrect. because the distance between the edge of film and the edge of collimation is not equal for each borderway. Next, the alignment between patient and IR is evaluated by comparing the distance between the edge of the film to the central structure. In this radiograph, the alignment between the patient and IR is incorrect because the edge of film to the central structure is not equidistant. The last point for alignment, the alignment between X-ray tube and the patient is evaluated by comparing the distance from the edge of the collimation to the central structure. In this radiograph, the alignment between the X-ray tube and the patient is incorrect because the distance from the edge of the collimation to the central structure is not equal. For the centering point for this radiograph is at the soft tissue of the elbow, while the standard centering point for this projection is at 2 cm distal towards the wrist to the lateral condyle. Next point is collimation. The collimation should be done to all four borders of the film and should include at the superior border. Structure that should be included is 1/3 humerus. At both lateral borders, structure that should be included are 1/3 radius ulna. At the inferior border, structure that should be included is soft tissues of the elbow. There is no evidence of radiation protection apparatus visualized on the radiograph. We move on to the exposure factor. The KVP used is adequate for penetration and the radiographic contrast because the bony cortical outline of the teeth structure, which is coronoid and humeral condyle, can be seen on the radiograph. And the bony cortical outline of the thin structure, which is olecranon process, anterior and supinator fat pads outline, also can be seen on the radiograph. For the MAS use, the MAS use is also adequate for details and density because the bony trabecular pattern of the thick structure, which is coronoid and humeral condyle, can be seen on the radiograph. Also, the bony trabecular pattern of olecranon process also can be seen on the radiograph. Hence, the exposure factor on this radiograph is optimum. Then, let's discuss about the marker. There is an evidence of the incorrect anatomical marker shown in the radiograph. The correct anatomical marker is right, not left, and it must be placed appropriately while not superimposing with any region of interest. Aesthetic value. The film size used is 10-12 inches, which is sufficient to demonstrate all the structures of interest. There is no evidence of artifact on the radiograph. Last but not least, the criteria of placement method is name. The patient's name and ID, date of examination, place of examination are clearly visualized on the radiograph at the appropriate area and not superimposed with the structure of interest.